It's a pleasure and an honor to speak here in Rotterdam every time to be invited, and I thank the organizers for kindly inviting me. Pruritus and in liver diseases. This is a long story. It is 300 years ago that Mauritius Reverhorst and Giovanni Alfonso Borelli were the first to describe evidence for an enterohepatic circulation of molecules which they at that time did not know. And it turned out bile acids are one of them, but there are various other molecules undergoing enterohepatic circulation. And they did the first experiments with dogs 300 years ago. We know today. We know today that impairment of bile secretion, or at the level of the hepatocyte, at the canalicular membrane mostly, or at the small or large bile ducts, may induce pruritus. But we don't yet understand the pathophysiology. And that's the first question then. And you already heard some numbers in the last talk. Which liver disease is most frequently associated with itch? You have 4 options: alcoholic steatohepatitis. Please start with voting. Intrahepatic cholestasis of pregnancy, primary biliary cholangitis, primary sclerosing cholangitis. These are the 4 options. And you heard the 80% of the PBC. And I think you heard that very well, because this is number 1. I think we can stop here. And it's quite kind of a nasty question. We can go on with my slides, please. It's a quite nasty question, because intrahepatic cholestasis of pregnancy is defined by pruritus. So intrahepatic cholestasis of pregnancy is 100% pruritus. So you were not so good. So I can still add something. We know today at the hepatocellular level, there are several diseases we know. ICP is the model disease for hepatocellular cholestasis: hormones, estrogens, and also anabolics, testosterone, for example, in susceptible individuals. Drugs, benign recurrent and progressive familial intrahepatic cholestasis, alcohol, HCV. Interestingly, HBV, very low rates of itch. PBC, classical disease. PSC, you heard about it, and all several other bile duct diseases. Now, okay. What do we know about itch? Since about 15 years, from German neurophysiologists, we know that there is a specific itch fiber which senses itch stimuli, and everybody knows the histamine response, itch response. But these itch fibers, these are unmyelinated C fibers, and they are in the skin, in the cutis, and they sense from receptors which they carry in their endings. They sense the itch signal to the dorsal root ganglia, then the dorsal horn, the spinal cord, and the central nervous system. And what we know already for a long time, scratching reduces itch, at least temporarily. And this is just because there is an interaction between pain signals and itch signals, and pain signals alleviate the itch signal. So that's why we are scratching when we feel itch. My second question before I come to the pathophysiology, and you may already answer it because you heard it already in the last talk. Which drugs are recommended in EASL CP guidelines as first and second choice for the treatment of pruritus in cholestasis? Option A, cholestyramine and rifampicin. B, cholesevilam and naloxone. C, naltrexone and sertraline, and D, obeticholic acid and ondansetron. Please vote very fast. I think this has already been answered. We stop here. Thank you. Can I have the next one, please? Yeah, but we learned a lot from all the methods which have been tried to treat itch. We think the potential pruritogens in cholestatic liver disease particularly cholestatic liver disease, that they accumulate in the systemic circulation. Why do we think that? This is the table you already saw, the European Clinical Practice Guidelines. I had the honor to chair these guidelines, and we made this list where you saw the graph, and we put these 4 drugs with more or less evidence on the first 4 steps. Everything else we at that time said is experimental. But when you look at a patient who undergoes mass treatment for intractable itch or plasma separation and absorption, what we did in Munich as an outpatient in an outpatient setting, it's always the same what happens. For a short time, these patients have relief, and some of them are lucky and have for a longer time. This is data from Albert Parés from Barcelona, and this is before and after mass treatment, and then after 30 days, in some of them it was fine, but in most of the patients the itch comes back. And you heard it all also in the last talk. So this is only temporary relief in many patients with really refractory and untreatable itch. Second, we think pruritusins are secreted into bile. Why do we think that? And Maren Harms also mentioned that, nasobiliary drainage. This is a graph from 4 patients which I myself drained in 2005, 2006. And I was lucky with these 4 patients because this is really a high risk of pancreatitis. And the study which was just shown in APT had a high rate of pancreatitis. Unfortunately, these are young patients often, non-dilated bile ducts, so they are at risk of pancreatitis. I was lucky, but I saw exactly the same thing, what was just reported. These patients, when you saw them the next morning, it was amazing. These were new human beings. They had slept for the first time in months overnight, and they were completely happy, these patients. But after taking the drainage away, the itch comes back. So also this is only a transient measure, but it tells us there is something in bile which causes itch. And cholestyramine, you already heard about it, it binds bile acids, but it binds also all other kinds of molecules, amphiphilic molecules. So don't put all money on the bile acids. And the third thing, we think pruritusins are bioformed or biotransformed in the liver and or the gut. Why do we think that? Because the most efficient treatment is rifampicin. And this is the only one which we gave a 1 and an A1 evidence for treatment of itch in cholestasis. And what was thought for a long time is that it works in the liver cell by upregulating, among others, CYP3A4, one of the important biotransformation phase 1 enzymes, also biotransformation phase 2 enzymes and transporters. But we have to discuss that further. And the fourth point is effect of naltrexone and sertraline. We think that opioidergic and serotoninergic actions are involved in the central sensing of the signal of itch. Here. This is what we indirectly think of the itch in cholestatic liver disease. But what causes now the pruritus in cholestasis? And this is from 2,000 years ago, and I like that a lot. Areteos the Cappadocian, he lived in Ionian. He was a very famous physician in the era of the Roman Empire in the 1st century after Christ. He was one of the authorities, and he said pruritus in jaundice patients is caused by prickly bilious particles, and I think he was already there 2,000 years before us, so we shouldn't be too proud when we make small advances in our knowledge. Next question, the serum activity and serum level of which molecule has been shown to be associated with presence and intensity of pruritus in various cholestatic liver diseases? Is it autotaxin, bile salts or bile acids, bilirubin or histamine? And please vote now. Autotaxin, bile salts, bilirubin and histamine. Which one of those has been shown to be associated, the levels have been shown to be associated with intensity of itch in various liver diseases, PBC, PSC, pediatric cholestasis, intrahepatic cholestasis of pregnancy. So this was the only difficult question. I'll leave it for a moment. Yeah, the right answer will come very soon. What did we do? When I came to Amsterdam almost 10 years ago, Andreas Krämer, he was a fellow of mine in München, and he came with me to Amsterdam to work on itch. And in Amsterdam was Ronald Oude-Elfrink. He's a biochemist, and I know him since 25 years. And we said we want to solve the itch. This is you have to have high aims. But we started, our first project was itch. And Andreas Krämer worked 1.5 years without any results. For all the fellows here, don't be too disappointed when it doesn't work in the beginning. No data in the beginning. What was our idea? We thought we take serum of itchy patients, and we put it on different neuroendocrine cells with different patterns of receptors, and we look whether these cells show a reaction to the pruritic serum and not to the non-pruritic, also cholestatic serum, and to healthy controls and so forth. And all the cell lines he tried, nothing happened, and he measured cytosolic calcium as a second messenger. And after 1.5 years, he found a neuroendocrine cell lines which reacted, and which only particularly reacted to the pruritic serum. And then he did all kinds, under guidance of Ronald, he did all kinds of extraction filter, blind dye extraction. So we knew it's a small molecule, it's amphiphilic, hydrophobicity goes up under protonation. It was no peptide because proteinases had no effect, and pertussis toxin showed inhibited the effect. So it was a G protein coupled receptor which was involved in the action of these cell lines. And our best possible guess was at that time, it has to be lysophosphatidic acid. And then he injected it into mice, and the mice started to itch. So we had a proof in the experimental animal that lysophosphatidic acid is inducing itch, and another Japanese group had done the same. They also showed that it can cause itch. And that was lysophosphatidic acid, and you heard about it, but luckily you didn't hear about the autotaxin. And autotaxin is the enzyme which splits the choline from lysophosphatidyl-choline. We all have it in the blood at high micromolar concentrations. And this is the product from phosphatidylcholine, the major phospholipid we have, particularly in bile. And we saw that lysophosphatidic acid was indeed enhanced in these patients, but we also saw after 6 months or so that when you put your tube on the bench, within half an hour, the concentration of LPA increased. It's like ammonia. You really have to have it on ice, otherwise it's continuously formed in the blood sample. So we didn't trust our results, and luckily Ronald then came to the idea to develop this test, autotaxin activity, and this is extremely stable, the autotaxin. So from that time on, we went with autotaxin, and here you see the model of this enzyme, which is soluble, which is in the blood, and which takes up the lysophosphatidyl-choline. This is then split, the LPA is coming free, and this is released at the LPA receptor. We know 6 receptors, different receptors, and then there are different cascades which are activated, and we still have to identify the exact cascades. We are on the process of that, which then causes the itch. It's also important in oncology, migration of tumor cells, many other effects for LPA. You saw this slide. Andreas Krämer did a major effort to collect all these patients, different kinds of itch, like in Hodgkin's disease or like in uremic patients. But the only prominent are the cholestatic patients, where is a highly significant difference. and also a clear-cut association of itch intensity with autotaxin activity intensity. We later showed this in other diseases in other publications. When you look then at the autotaxin activity and therapeutic efficacy in pruritus or cholestasis, we looked at different situations, treating patients with, this is a Rotterdam study, the Rotterdam, Amsterdam, Utrecht study, which was negative. Colesevelam was not better than than placebo in reducing itch. You see a mild decrease. Here you see a marked decrease by rifampicin in itch activity. Mass treatment done in London, you see a marked decrease. And nasobiliary drainage, these were my Munich patients, also a marked decrease. And when you look then at the autotaxin levels, you can see it really mirrors the itch intensities under these different conditions after treatment interventions. Where is it formed, the autotaxin? It's formed ubiquitously, and there is a marked difference in mouse and man. Cholestatic mice don't itch, so we have no animal model. We for a long time, didn't understand why cholestatic mice are not itching. Interestingly, they have no production in the intestine, whereas human beings have marked expression in the small intestine. And pancreas, and when you look at these two, pancreas is 70 grams, and the small intestine, these are 3 meters of tissue or 4. So this could be one of the sites where autotaxin is formed, but we have to be careful. We don't know which autotaxin is responsible in cholestatic disease. But we think at this moment that autotaxin and the formation of lysophosphatidic acid is playing a crucial role in the development of itch. Interestingly, one of my fellows showed, Remco van Dijk, that rifampicin on the transcriptional level downregulates autotaxin formation. So we think that maybe the rifampicin effect, and it takes 2-3 days until it works that one of the effects may be downregulation of autotaxin at the transcription level via the pregnan X receptor. Question, what's future treatment? We speculate on autotaxin inhibitors. They are developed on the oncological field. Maybe LPA receptor blockers, but we don't yet know the exact receptor which needs to be blocked. So this needs to be very specific. You heard about, the autotaxin, we didn't find autotaxin and we didn't find LPA in bile. There must be something else in bile. And we call it the factor X. And we have certain ideas about this factor X, but we haven't yet identified the factor X. But this is the one which is probably removed by nasobiliary drainage. But what we did is, this is a couple of years ago, and I did it with the idea that ductular proliferation in PBC, PSC patients may play a role, and you heard the alkaline phosphatase association with pruritus, that inhibiting inflammation, NF-kappa B dependent inflammation and proliferation, fibrates should be active for itch. And I just treated a couple of patients, and Albert Parés did the same independently in Barcelona, and we had the same effect, striking effect, that these patients were free of itch after a short time. But we have to do it in a trial, so we set up this FITCH trial, fibrates for itch, and this is now a multi-center Dutch and Barcelona trial, and we hope to do this within a year to find an answer, fibrates versus placebo, to see whether the fibrates really have a good effect. The last hit is ASBT inhibitors. There are controversial reports, but the last one in Boston showed a beneficial effect. And what may this be? So maybe the bile acids are pruritogens, co-pruritogens, because TGR5 may also mediate pruritus in mice, induced by extremely high levels of a bile acid, deoxycholic acid, which you don't find in unconjugated deoxycholic acid, which you barely find in cholestasis. But this is an interesting finding, and we have an idea about that, but we have to show that. bile acids, no correlation at all in our studies with itch intensity. So I still remain with the statements bile salts are not the pruritogen. They may be involved in the whole process, but not the pruritogen. So autotaxin was the good answer, A. And this is the summary of what we know today from itch, what we think. There are many open questions still. What is the role of the hepatocyte, cholangiocyte, and ileocyte in pruritus of cholestasis? All are involved. What is the biliary factor X in pruritus of cholestasis? Do ATX inhibitors, LPA receptor blockers, ASBT inhibitors, and PPAR agonists ameliorate pruritus in cholestasis? And you can do all this work only in collaborations. This is our group, and these are all the collaborators. And you see here Rotterdam, for example, Utrecht. And I thank you all for your attention.